I have no financial disclosures. I wanted to thank the organizers of this conference for the chance to speak with you. My name is Michael, and I'm speaking to you from Seattle, Washington, the ancestral homelands of the Coast Salish peoples who have lived here from time immemorial. I wanted to express my deepest respect and gratitude for our indigenous neighbors, the Duwamish, the Suquamish, Nisqually, Snoqualmie, and Muckleshoot tribes, for their enduring care and protection of our shared lands and waterways. I'm also speaking to you from approximately 3,000 feet from the Capitol Hill Occupied Protest, or CHOP, formerly known as the Chaz, or the Capitol Hill Autonomous Zone. This is a place that was birthed by police brutality against unarmed people who were protesting unchecked police brutality against Black people. I need to start this cure talk with politics because HIV is political. It is affected by politics in real ways, and if we do not insist that HIV is political, we will lull ourselves into believing that it is not political. HIV is political, and so too will be an HIV cure. If recent events have taught us anything, it should be that we should not make any presumptions about our neighbors or know how they wish to solve the problems facing the world. If we think of HIV as not political, we will lull ourselves into believing that people are well served by being the object of charity, and they are not. And that new therapies and discoveries towards an HIV cure will continue despite budget cuts. They will not. And that people living with HIV are not affected by other institutional oppressions like racism, homophobia, discrimination, ableism, ageism, and great economic disparities, for they most certainly are. HIV is political, therefore HIV cure is political. Think of this another way. Is this glass before you half empty or half full? We use this proverbial phrase to indicate that a particular situation could be a cause for pessimism or optimism, or maybe it's a litmus test to determine someone's worldview. But I want to use it to guide your thinking about the ways you can approach getting involved with HIV cure-related research. The more familiar deficit approach focuses on the problems, needs, and deficiencies in a community. It designs services to fill those gaps and fix the problems. As a result, a community can feel disempowered and dependent. People can become passive recipients of services rather than active agents in their own and their families' lives. The shift from a deficits-based approach to an asset-based one requires a change in attitude and in values. Clinicians and researchers have to be willing to share power. Instead of doing things for people, they have to help community members do things for themselves. Working in this way is community-led. It's long-term and it's open-ended. An empowered community may not choose to act on the same concerns that clinicians or researchers see as the priorities. Here's an example to ponder. In speaking with the people living with HIV about the research that is related to an HIV cure, inevitably, I find that three burning questions tend to be asked. Who is going to get it? How much is it going to cost? And when are we going to see it? Often these questions can frustrate researchers. Maybe they grow tired of the same questions arising again and again, but that's seeing it as deficits. Perhaps instead, we should see in these questions a burgeoning advocacy around cure, one focused on promoting civil rights, ensuring equity, and optimizing the clinical trial pipeline. After all, that is the legacy left us by our ancestors who dared to act up. So let me call out first to you who think of yourselves as community. Yo, community, it is time to talk to you or with the people who have yet to be seated at the cure table. Most HIV cure trials are conducted, as you know, in high-income countries and disproportionately enroll white men. That leaves us with a relatively small group of people who are knowledgeable about the basic science and the clinical progress of cure-related research. It is up to community to welcome to the cure table a broader scope of these people from low-income and middle-income countries. And also, don't forget places that have a high HIV prevalence, which sometimes are the cities, neighborhoods, or zip codes that we live next to. Giving these new allies a prominent seat at the cure table will do more to clear up misconceptions and myths and dispel distrust and doubt than any program that tries to fix things. We cannot wait for someone else to do this. Community must help community. So let us reach our arms out far and wide and welcome the people we know to be missing. Let us place them front and center, amplify their voices, and listen to what they have to say. Doing so will foster understanding of the facts, it'll build trust, and perhaps instill some hope that one day we can still achieve a cure for HIV. And next, I'd like to address the clinicians in the room. Yo, clinicians, or healthcare providers, or primary care providers, whatever you want to call yourself. It's time to start talking to your patients, your clients, about HIV cure research. As the Cole Porter song goes, if not you, who? In you lies an untapped well of potential advocacy for cure research among the people living with HIV that you care for. You likely already have built partnerships with your patients, your clients living with HIV, and that's the foundation of the care that you give them, so you're halfway there. So this relationship between healthcare provider and patient really became evident to us in Seattle when we published some qualitative data from a focus group discussion study that we did with people living with HIV in the Seattle, Washington area. And it was on the acceptability of cell and gene therapy approaches to curing HIV. Participants expressed fear about the CGT research, concerns about the risks, and voiced very significant mistrust of research in general, believing there already was a cure for HIV and that was being withheld from the poor. The trust conferred by these people to their primary HIV care doctor sharply contrasted with all this distrust in medical research. We concluded from this research that the support and the approval of participants' primary HIV care doctors will be critical in making decisions about clinical research participation in cure-related studies, especially when there's no direct benefit. And so if you need further evidence, please take a look at these percentages. 83% of individuals surveyed said that a doctor's recommendation would likely influence their participation decision. And 58% of those say they never or not very often considered research as an option in discussions with their doctor. 85% said they would be comfortable talking about this information with their doctor, but only 17% had actually presented clinical research information to their doctors. So there's a bit of a disconnect here in what people are saying and doing. And when I say clinician, mind you, it's not just clinicians, it's not just physicians, it's anyone who is a caregiver for people living with HIV. If you take care of people with HIV in any capacity, I am talking to you. You owe it to your HIV positive clients to keep up to speed with accurate cure-related research developments. So there's still so much to figure out around cure. We must place it in context with HIV prevention and treatment. The scientists that I'm lucky enough to work with at Fred Hutch created actually a mathematical model of heterosexual HIV transmission to evaluate the impact of ART, HIV prevention interventions, and cure on HIV prevalence and incidence. They found that a cure would have a limited impact on HIV incidence if only patients on ART were eligible for cure. But it had a significant impact on HIV incidence if untreated patients were directly enrolled into cure programs. Meanwhile, concurrent HIV prevention programs would moderately decrease the percent of ART-treated or cure patients needed to achieve elimination. And when it comes to ending the HIV epidemic in America, it may be true that we do not need a vaccine or a cure in order to achieve our goals, but we ought to reconsider this in the way we approach this important work. People living with HIV can feel left out of the ending of the HIV epidemic plan. Many do not understand how lowering transmission will end the epidemic and why art and PrEP are enough to do it. In their lived experience, the epidemic will not end until they are totally free of HIV. Talk of cure in this context would be aspirational for people living with HIV, as well as for the general public. So, to conclude, yo, community, you don't have to wear a lab coat to help us find a cure for HIV. And yo, clinicians, you don't have to work in a lab to help us find a cure for HIV. There are many ways for community and for clinicians to get involved with and get informed about HIV cure-related research. If you pay attention, this meeting will offer you a few. Your unique talents are very much needed in ways that are left for you to figure out. But trust me, there are pathways that no one has dared yet to map. So remember, that proverbial glass is half full. And remember, there will be no cure without you. Thank you very much, and I hope you enjoyed this meeting.